Good afternoon and welcome to today's program titled The Impact of Utilization Management and Documentation on Your Revenue. I'm Tom Valentino, Senior Editor of Addiction Professional. Today's program is co-sponsored by Foundations Recovery Network and Panacea Healthcare Services. Thank you to our sponsors and to our audience for giving us your time and attention today. Before we get started, we have a few details we'd like to go over. To submit a question or a technical issue, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program to ask a question. A copy of today's presentation will be available within 24 hours. Check your inbox for an email from Addiction Professional Webinars. A special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the presentation. At the end, do not leave the web page. The site will automatically redirect you to a survey. This must be completed in order to generate your CE certificate. For those watching in a group, please download the group submission guide and the resources tab and follow the instructions provided. Please note, CE credit is not available for the archived webinar. It's only available for the live event. Finally, for those of you who tweet, please tweet along with us today using the hashtag #APLiveWebinar. At this time, it's my pleasure to introduce our speaker, John Raymond. As a senior executive at PRRS Inc., John brings drive, discipline, and dedication to helping his clients not only survive in the chaos of the behavioral healthcare space, but thrive and grow as well. He has held several executive-level positions in the substance abuse industry, including positions at AAC, HCA, and for the last 5 years at PRRS. He is an addiction and suicide prevention counselor, interventionist, public speaker, and utilization management professional. Thank you, John, for taking the time to speak with us today. And with that, the audience is yours.
Thanks, everybody, and welcome. Happy Halloween, first of all. My name is John. I'm the Chief Marketing Officer at Panacea Healthcare. And if you have any questions, I am available at john@panaceahcs.com. So let's get into it. What we're here to talk about today is utilization management and the impact of utilization management and documentation on your revenue. It's important to understand that now more than ever, UR is key to a successful and healthy revenue and claims management cycle. That means that without proper UR, now more than ever, it will impact your rates, your reimbursement, how quickly you're reimbursed, and whether or not you guys go into audit or not. Again, welcome. Happy Halloween. This is the Halloween edition of my presentation. If you guys have seen or talked with me before, there's going to be a lot of new stuff in this one. So let's start off by defining utilization management. What is utilization management? Utilization management is the evaluation of the medical necessity, appropriateness, efficacy, and efficiency of the use of healthcare services, procedures, and facilities under the provisions of the applicable health benefits plan. It's important to understand a couple of things here. Medical necessity, appropriateness, efficacy, and efficiency. The payers are looking for, are the clients being treated at the right level of care for their current needs? And are they being treated efficiently to titrate them down? And is what's happening having impact or efficacy? Is what you're doing adding value to treatment? The important thing to know is now how they look at this is through your documentation. Now more than ever, the payers are asking for charts. They are pulling a ridiculous amount of charts to review for exactly that, efficacy. Is the service you're provided worth paying for? Does it have positive impact on a client's treatment? These are the questions that the payer is looking to answer. Is the service appropriate for that level of care? If you have a client that hasn't drank in 16 days, why are you putting them in medical detox? So let's break down medical necessity. Medical necessity is defined as accepted healthcare services provided by healthcare entities appropriate to the evaluation and treatment of a disease, condition, illness, or injury, and consistent with the applicable standard of care. Is what you're doing right for your patient at that moment, both clinically and medically? Is what you're doing going to help? These are the questions that they're looking to answer. The behavioral health medical necessity criteria are guidelines used by utilization review and care management staff to determine when services are medically necessary. So this is being driven now more than ever by our cry as an industry for parity. Parity, we screamed, treat us equal, treat us the same. We want to have no restrictions or the same restrictions as your medical plan. So the payers finally acquiesced and said, okay, and parity law came about. But what parity has done is put a primary focus on the medical in medical necessity. In 2017, we saw almost a 40% reduction in therapeutic staff at the payers. Now, those staff were laid off and replaced with nurses. Nurses making the medical assessments on the patients. Nurses who are looking for just the facts, ma'am. Nurses tend to focus primarily on symptomology, services matching symptomology and treatment, and does this tie back to a continuous plan for care? So when we say efficacy, what efficacy is the ability to produce a desired or intended result. Is what you're doing having positive impact on the client? If you have a client who has a substance abuse problem and you put him in an underwater basket weaving class, you better make sure that you can talk about how underwater basket weaving is therapeutic for that client and show the true value of that service in your documentation. Because if you can't, it's going to be a non-billable service hour. We'll talk a little bit more later about how that will negatively impact your claim cycle. But guys, you have to understand efficacy is the key word that the payers are looking for. For a long time, providers would submit documentation that said client was in group. And that was it. And what that doesn't tell them is, did the client do anything? Was the client helped? How did this tie back to a treatment plan? What did this do to help ensure the client doesn't relapse, have another issue, is getting treatment or help for the problems that they have? Client is in group is not a note. It shows no efficacy. So they are looking to see that you have impact with what you do. Part of that efficacy comes with documenting symptomology. What's happening? We used to see a lot, notes would say, client was anxious. Now I want to see client was anxious as evidenced by. We want to see you documenting psychomotor agitation, sweating, restlessness, eye movement, inability to sit and control themselves. Any physical symptomology that you see will add justification to the diagnosis of anxiety, and it must be there now. When we talk about efficacy, we're talking about how quickly can we manage these issues? How quickly can we titrate down to a lower level of care? They are looking to provide the least restrictive level of care at all times. From a payer standpoint of view, they look at providing more treatment when a client is appropriate for a lower level of care as overdosing your client on treatment? Is the client being treated at the level of care truly needed to manage their crisis symptomology? Once that crisis is over, how quickly are you moving them to a level of care where they can manage an appropriate level of care based on their idea of what's appropriate for the client, not yours? Is the client being treated at the level of care authorized? This is a big one nowadays. If you have a client that starts in your care at the detox level of care and then steps down to residential and does 7 to 10 days of residential, 14 days of residential, and then you call in the off and the care manager steps them down to partial, and you accept partial authorization or day-night authorization, you must step that client down. Because if documentation shows otherwise, you will be beholden to the partial level of care documentation. Which means if you're billing them at res, they're going to say you're billing outside the scope of services, and they're not going to allow you, they're not going to pay you for that day. So when we talk about what's important for treatment and efficacy and appropriateness, when we talk about the changes that Parity brought about, all of this is being looked at for two reasons. A, our cry out for parity, which we already discussed, and fraud. You know, the substance abuse and mental health industry has been plagued by less than reputable facilities with UA fraud, fee forgiving, enticement to treat, service hour fraud, and the payers have taken that very, very personally. What they want to see now is every minute that they are in group, what they're doing, does it have efficacy? Does it tie back to a treatment plan? It must tie back to a treatment plan. You can't just willy-nilly throw treatment at your clients. Each client has to have an individualized treatment plan that has impact on where they're going. And guess what? If your client changes, what happens? Your treatment plan has to change and get updated. And then the new groups have to tie into the new treatment plan. This is what they are looking for now, and in my opinion, this is just good services altogether. 2017 saw a huge paradigm shift in utilization review. The requirements for changes in documentation, changes in the appeals process, changes in policy reimbursements, changes in medical necessity criteria have changed almost quarterly for each payer this year. We are seeing new MNC roll out at least once a quarter right now as they try to adjust to their new rules as well. Changes in how claims are processed. Every major payer, Cigna, Aetna, Optum, Blue Cross and Blue Shield, have all had huge shifts in how they authorize, what's required, how they process, and how they pay claims. There has not been a bigger shift in the industry since the onset of managed care back in the day. You know, what has had the most impact for us as providers, us as therapists, nurses, facilities, is documentation. Group notes have had the biggest impact. They are still focusing on putting the medical back in medical necessity criteria. All your group notes must tie into a treatment plan. Documentation must reflect patient-specific centered care, meaning those notes, each group note must tie back to what's happening to that patient at that time. And if you don't document, it didn't happen. If you miss 2 hours of service documentation in a day, that day now becomes billing outside the scope of services. The whole day is washed out. They're not going to pay you for that day. Guess what? If it happens more than 3 times in a chart, they're not going to pay you for the entire claim. They'll put the entire chart in review, which will probably lead to a request for 5 charts, and then 40, and then you're in audits, and then you have prepayment issues, and now because somebody failed to document, you're not receiving any money from this payer. So documentation is important. If you don't document, it didn't happen. I cannot stress that enough. If you don't document, it didn't happen. If you don't document, it didn't happen. Individual notes must reflect acuity. This is not a time as a therapist to talk about how awesome you are, how great I am as a therapist, how good Johnny's doing in treatment. I need to know what's wrong, why he needs this level of care, and how long you expect he or she to stay in this level of care, and why they can't transition down. What are their barriers to making that move down? You must go over any challenges that are presented and plans to address those challenges. You cannot chart progress only. I cannot state this again. You guys just can't do it. You cannot chart progress only. I like to use what I call the Oreo cookie method, where you have problems on the top, progress in the middle, and problems on the bottom. So you got the two chocolate outsides and the creamy center on the inside. That's the Oreo cookie method. If you can use the Oreo cookie method and think about OREO, that delicious cookie that everybody loves to eat, you can't have an Oreo without all three pieces. It's essential. If not, you just have what my daughter likes, which is just cream. But you can't have that. You have to have the cookie to make it an Oreo cookie. All right? All your notes must tie back to the treatment plan. If something pops up in individual that turns you to the left or the right, again, you must adjust the treatment plan. You must make these adjustments all the way through the chart, all the way through the planning, all the way through next stages, because if you don't, you're not addressing the real issue at hand. And again, guys, if something happens, never present a problem without a solution or an intervention towards a resolution. Right? I say this all the time, and this is where people fall short the most in documentation. You know, Johnny was in group. He spent all group talking to Miranda. He weren't paying attention. He left group. On his way out the door, the counselor said to him, you know, Johnny, you weren't paying attention in group. Johnny got mad and hit the counselor in the face with a chair. End of note. There's no intervention there. What happened? Where is the follow-up for this? I need to know what your next steps were to address this issue. Even if it's recommending John for administrative discharge, or put John on female ban, recommended for administrative discharge, all of these things have to be laid out in that note. Refer John to primary counselor and program owner to decide what will happen. All of that stuff has to happen. The note can't just end at the problem. Or, Jamie was in my office today crying. She seemed very sad and upset. She wouldn't open up about what it was. This therapist told her to journal about it. End of note. That seems like it has an intervention. It doesn't. Yes, you told her to journal about it, but you did not address how therapeutically you're going to help her sadness. A better version of that would be this therapist told Jamie to journal about her issues and bring her journal to the next therapy session where we can go over it. In the meantime, if she seems sad beyond her ability to deal with, I told her to come to me immediately. And I also advised the nursing staff and the tech staff to check on her at least 3 times an hour as client presents with some passive suicidal ideation. Right? You guys must document the issues that you're having and the and the solutions to the problems that are presented. If not, your chart winds up looking like a whole bunch of problems without you doing anything about it. And the payers are going to say, guess what? You didn't do anything for them. Send them home or send them to another facility that will help. Family sessions. Payers require family sessions. They all do. They all view family sessions as an important part of treatment. They think addiction, mental health is a family disorder because it is. You cannot address a family disorder without including the family. Some of them require it within the first 24 hours. Documenting follows the same guidelines as individual. Family challenges must be met with family interventions and documented. And if a patient refuses family therapeutic involvement, you must document your interventions to get that family involved. You must document why. It must be a legitimate reason, not just because they're mad at mommy and daddy that day. If they're mad at mommy and daddy that day, you must have an intervention for what you did with that and document it. Because if you don't document, it didn't happen. And payers are kicking out charge for family therapy faster and faster now. This is a must. Remember, when you're documenting, nothing is irrelevant. Document all subjective and objective physical symptoms, emotional symptoms, behaviors outside the norm, positive or negative, mostly negative. And if you don't document, it didn't happen. Again, if you don't document, it didn't happen. Here's a banana. So, let's get to the group notes. The group notes have had the most impact as far as documentation. And when I present this, I always say yes. This means more work for you. I sat on the other side of the fence and I had to do many a group note and I hated it. You're in group with 30 people. All of them have their own challenges. After group, you just want to go and wind down, or maybe you have to go and run into an individual, or go and run into another group, or go and help somebody pack up their suitcase to leave. But you must document. You must document for each patient. Each group note must include the title of the group and the length of the group. It must include a group description. What is this group generally about? The group must be tied into the treatment plan. Each note must be a minimum of 1 paragraph, 4 sentences specific to that client. I need to know what's happening with Johnny in the group. If Johnny is a gray man, a middle-of-the-pack patient, someone who goes unnoticed or doesn't actively participate, you, as a therapist, must draw them into group or make an attempt to. Bring them in. Be aware of them. Have them participate. Or document why. Grab them afterwards and say, hey, Johnny, what happened in group? I don't see you participating. Document what that conversation looks like. You guys must show impact of treatment for each group. So I want to talk about some of the do's and don'ts of documentation with group notes. These are actual group notes. If you're on this webinar and they're your group notes, I am very sorry. So you can see the first note says session summary, duration for 3 hours, check-in and assignment complete, discussion on family systems, process, group, and UAs. For 3 hours. That's what happened. 3 hours of this patient's life can be summed up, not even in a full sentence, but in bullet points. And I guarantee you that every patient that attended that group had the same set of bullet points. Yet they wanted to bill for this group. I can tell you very specifically that this group was denied. That's 3 hours out of service. The day was denied, and eventually the entire claim was denied for billing outside the scope of services. The next one is even better. This is an individual session note. I love this one. Client signed in and turned her hand in. Client stayed only 5 minutes and left to go to work. Client came to an individual session, a billable hour, turned a picture of her hand in, and then left to go to work. So she shows up, she runs in the office, and she says, "Erica, here's a picture of my hand. Gotta go." And the facility wants to bill for this hour. Was a therapeutic hour of service provided? Negative. Can you bill for this? Negative. What does this do for your claim? It throws the entire claim out of cycle for billing outside the scope of services. One group, one bad note is all it takes, because they're looking now. And the scary part is that one bad note, that 5-minute hand turkey picture whatever note, will be the first red flag. And then they will ask you for 5 more charts. And then they will ask you for 40 more charts. And then they will stop paying for treatment while they review these charts. Your utilization management and documentation go hand in hand like peanut butter and jelly, salt and pepper, peas and carrots. You must have what's reflected in your UR, reflected in the charts, and those must be a reflection of the services provided that show efficacy in treatment. Because if you don't document, it didn't happen. And if you document poorly, you're a bad therapist and it didn't happen. When we talk about documentation, here are a couple of other things that you shouldn't do. How about 1 hour, no notes? Or individual participation notes with no note. If you didn't document, it didn't happen. This chart has just been flagged for audit. Have a nice day. It won't pass, by the way. That's 2 in 1 chart. It won't pass. Guys, again, you're going to hear me drill this into your head. The one takeaway, if you take anything away from this presentation, is if you don't document, it didn't happen. What are some things that you need to put in your documentation? In a group note, in an individual note, every note should have a mini mental status exam. Really quick, look at your patients. Make an assessment of what's going on with them. Check in with them and see where they're at. By the way, that knocks out 1 of your required 4 sentences in a paragraph. John seemed very anxious today, as evidenced by psychomotor agitation, rapid eye movement, and tangential thinking. He was fidgety in group, and I was unable to assess what was driving the anxiety. Stood up a bunch of times in group. I asked him, stop interrupting group, and if he had a problem sitting in his seat, to just stand quietly in the back of the room so he could still participate. After group, I checked in with him. He said that he was feeling very anxious, didn't know what it was from. I sent him to his primary therapist and also sent him to the nurse to see if there was a medical issue driving his anxiety. I will follow up with John on our next group together to see if he has calmed down. End of note. If you present a problem, the challenge, you must present the solution. John was feeling anxious. I checked in with him. He was unable to identify why he was feeling anxious. His anxiety was evident by the symptomology presented, so I sent him to his primary therapist and the nurse to see if either the therapist could pull the feelings out or the nurse could identify a medical reason. for why his anxiety happened. Never present a problem without an intervention. And remember, document, document, document. Because if you don't document, it didn't happen. Why are we having to do all of this new documentation? Efficacy. Are you providing a recognized therapeutic service that has a direct impact on the recovery of your clients? The key words in that one are direct impact and recognized therapeutic service. I don't care if you run a Bobcat therapy service group. Unless you can show me the efficacy of Bobcat therapy, the payers are not going to pay for it. They're going to say it's experimental. If you have jellyfish painting as a group and think that you're going to get paid for it, it's not going to happen. You must have a recognized therapeutic service that has direct impact on the recovery of your client. So if your client is a primary behavioral health client and they are sitting in a substance abuse relapse prevention group and they have no identified substance abuse problem, does that have direct impact on the recovery of your clients? Negative. What that has is direct impact on wasting your client's time, where he or she could be bettering themselves in an individual session, in a mental health group, and vice versa. Is your therapeutic service cost beneficial to the payer? Are you expensive? Are you worth the money? Is the time that you're spending with your clients valuable? Does it have positive impact on their recovery, preventing them from relapse and coming back and costing the payers more money? Guys, make no mistakes about it. It's a bottom line issue with the payers. Substance abuse clients, in particular, are the most expensive single clients to a private health insurance carrier. They are more expensive than a terminal cancer patient. They are more expensive than a transplant patient. They are the most expensive, with the average person, the average addict going to treatment almost 4 times now. They are the most expensive for the payer. So the payer wants to know, are you adding value to my services by keeping them from relapsing? Are you utilizing measurement-based care to determine whether your client is or is not making progress? Are you paying attention and documenting the moves that your client makes in treatment? Is what you're doing helpful, and are you documenting that somewhere other than in the group note? Graphing this in the patient's chart is great. If your patient is just floating around like a zombie, not doing anything for their treatment, not participating, not having impact, what are you doing as a therapist to move them forward? Are you just sitting around like a princess or a Care Bear trying to figure out how they're going to get themselves better? You must be constantly working towards improving the therapeutic experience of your clients. Measurement-based care, showing what works and how, globally and by client, will add more value to you for the payer and have serious impact for you and your revenue cycle moving forward. I guarantee it. This is one of those things where you're building your reputation as a serious service provider with the payers. You're able to say to them, this is what we do, and this is how we know it has impact. But do I really have to do all this extra work? Poorly documented service hours or failure to document service can cause a denial for the whole day. one group, one individual note can deny the whole day and possibly the whole claim. Poor documentation leads to audits, puts you in special investigations unit. Prepaid audits are especially difficult because you have no money coming in from this payer. And if you have a one-payer saturated payer mix rather than a diverse payer mix, and that payer throws you into audit, you're going to have a serious revenue issue. All audits slow down your revenue cycle. There's no way to speed it up because what they are doing is reading your charts. All right, awesome. So just kind of circling back, do we really have to do this new documentation? Yes. It is valuable. It will help make sure that your revenue cycle stays on track. And it's just good treatment. It helps with follow-up care. It helps with care when you're not there, right? If I'm the primary therapist and all I document was John did great in individual today, end of note, and I'm out, and the next day Meredith has to cover for me, and she looks at the chart and there's zero real clinical documentation in there, she's got to start with my patient from ground zero, day one, or just half-step her way through the treatment. Good documentation matters. Good documentation drives excellence in care. Good documentation drives excellence in reimbursement. Guys, again, if you don't document, it didn't happen. If you don't document, it didn't happen. If you don't document, it didn't happen. And if you do a bad job at documenting, it doesn't matter. It won't count. What you did is null and void. So you might as well do a good job documenting. Let's talk about the medical necessity criteria. This varies by payer. ASAM is a factor, but not as heavily as previously. A lot of private insurance companies say that they use the ASAM criteria, but when push comes to shove, what they say is it's based on ASAM criteria, or we use an interpretation of ASAM criteria, or we use ASAM criteria in conjunction with medical necessity criteria from Anthem or Aetna or whatever payer you're talking about. So what they're saying is they're trying to legitimize their medical necessity criteria by saying it's based on ASAM, when really it changes every quarter and it's malleable to their needs. It's subjective based on their need to deny care or titrate care down. Make sure you guys are diagnosing using the DSM properly. Make sure your modifiers are in place. Make sure that you are giving actual diagnosis and not weird, one-off, one-number-away diagnosis. These will have impact in your documentation and your charting, and it will negatively impact your revenue cycle. There's a new focus on medical and the medical necessity criteria. Most payers provide their MNC online, but it is hard to find. And I can tell you that they do not provide it in what I would consider to be a timely manner, meaning they will release new medical criteria in January, and it will show up online in March with a January date on it. Staying on top of medical necessity criteria is something that you must do. And if you don't have the bandwidth to do it, you must get with a professional who studies these rules, who knows them in and out, who knows the payer criteria, not only for medical necessity criteria, but for billing criteria. You know, we have a department here whose sole job it is to just focus on understanding and adapting to the criteria for all of our clients. It's that important. Knowing your criteria is knowing the playbook. Knowing your criteria is knowing how to provide in the eyes of the treatment of the health insurance provider excellence in care. And at the end of the day, if you want to get paid from health insurance companies for what you do, it's the rule book for dealing with them. Private health insurance criteria supersedes licensure, it supersedes accreditation. It is the most stringent set of criteria that you will be held accountable to. In comparison to some states, and I get this all the time from my clients, well, my licensure doesn't require that. Yes, but your licensure, the state doesn't cut you a check. Aetna cuts you a check. Cigna cuts you a check. You need to do what Cigna says if you want to get paid. Understanding and interpreting the ins and outs of each payer and their medical necessity is the role of the Utilization Management Department. They are your front line. They are the ones who will fight the fight for you and help make sure that not only are you providing the standard of care that the payers are looking for, but that they can translate that information to the payers in a timely manner. Now, is that a guarantee? When dealing with private health insurance companies, nothing is a guarantee. I know all of you have heard the following statement: authorization is not a guarantee of payment. Verification of benefits is not a guarantee of payment. Claim status is not a guarantee of payment. I honestly feel like sometimes they should put payment is not a guarantee of payment. Because at any given time, they can say, nah, we're not going to pay for the services that you provided. But if you have proper documentation that supports their medical necessity criteria, you can appeal and say, wait, we did everything that you asked us to, and here it is. Pay us. And I have worked with facilities that have fought that fight and won because their documentation is rock solid. But unless your documentation is bulletproof, you cannot hope to win in those situations. I want to touch briefly on no-cert policies, policies that do not require authorization for specific levels of care. Back in the day, when I worked in admissions and I would see no-cert policies, I would get super excited. I was like, woohoo! We don't have to do anything, just bring them in and roll. However, 50% of policies that did not require authorization in 2015 now require authorization. 80% of all policies that are no-cert policies will deny on the back end and require submission of the medical records for review. 80% of those clients that you think you don't have to do anything for, what you don't have to do is call it in because they're automatically going to ask for the chart. And what we find is a trend where 80% of where people who have no-cert policies, they don't document because they feel like they don't have to authorize. These are not easy catches, guys. These must be held to the same standard as every other patient. You cannot lay back on your no-cert policies. Review the charts every 7 to 14 days, making sure that they meet criteria. So, what are some key takeaways? If you don't document, it didn't happen. What you do must be considered of value, not only to the client, but to the payer. Utilization management has had significant changes, and it's the role of your UR department or your UR vendor, like Panacea, to stay ahead of the changes and work with the payers to improve lengths of stay and reimbursement. Guys, I think Q&A is coming up here in a minute. If anybody has any questions for me, my email is john@panaceahcs.com, and I'm on the LinkedIn's at linkedin.com/in/the John Raymond. All right, Tom, I'm ready for you.
All right. Thanks, John. Very informative presentation. Before we get into the Q&A portion of the event, I would like to hand things over to Leah Boone from Foundations for a few words from our sponsor.
Here at Foundations Recovery Network, our grassroots movement called Heroes in Recovery has a simple mission: to eliminate the social stigma that keeps addicted individuals from seeking help and to create an engaged, sober community that empowers people to give back and live healthy, active lives. Join us in this mission at our 6K race series at these locations across the country. As a thank you for your attendance today, please enjoy the discount code Webinar 2017 to register for any future 6K events. Back to you, Tom.
All right, thanks, Leah. We've already had some questions coming in from our audience. However, we would like to remind you to use the Q&A area below the slides to submit a question at any time. Also, to download a copy of the slides, please check your email, as we will be having a link to download slides within the next 24 hours coming from Addiction Professional webinars. All right, let's get into some questions here. John, do you have any tips for documenting multifamily groups?
When documenting multifamily groups, you're going to want to have the impact of each representative and the impact of the patient relationship on each one and how that happens. It documents the same way as a regular group note. You're just documenting according to that patient and according to that patient's family and how that applies. You know, what we want to do is we want to make sure that, again, it follows the same thing. We're documenting to acuity. We're not documenting about puppies and sunshine and rainbows. We're using the Oreo cookie method. You know, documenting any challenges that the family presents, any relationship challenges by family of what's happening that impact the client or that is impacting the family in and of themselves, so that we're able to tie that back into a later session. If the patient is not present, we can tie it back into a session with the primary therapist to go over kind of family challenges and stuff. If the patient is present, what interventions were taken to address those issues and how that played out for both the family and the patient.
All right. This is going to be, I believe, a multiple choice question here. So in the residential substance abuse modality, do you recommend documentation for each group only, documentation for each group plus a summary note for the day, or documenting a progress note summarizing the entire day, listing all groups in participation?
I would say that the payers require A, documenting for each group. B is a little bit of extra secret sauce on there. So documenting for each group and then adding a summary for the day is excellent and just good therapeutic practice. You know, we want to make sure that we are giving the payers exactly what they need, you know, and exactly what they like. So that's the best practices to use. We want to give them the nice, juicy Krispy Kreme donuts and not any, you know, red hot chili peppers that they're just burning their mouth. We want to make sure that they're processing things in their own time and that they feel like they're getting what they want. So, again, individual documentation by note, and then a summary is awesome. That is, like, perfect.
All right. Let's see here. What do you suggest a facility can do when faced with a payer who never approves coverage for any patients at any level of care? They will approve levels of care for a patient that are not available to the patient in their geographic remote area and are not available at our facility.
That sounds like a very specific question, but when you run up against a payer that has what I would consider to be, like this person is saying, a facility-based bias, you know, if they just don't like this facility, like some people just don't like deviled eggs, you know, let's just either diversify that payer mix, or we need to work with legal counsel to find out why they're not meeting criteria. You know, if this is a single case agreement, we don't have a leg to stand on. But if this is a facility that's providing out-of-network services at a facility that offers those services, and they're just picking on the facility, this happens all the time. Getting legal counsel involved is definitely something that will have benefit. That's something that we can help with. Guys, give us a call, give me a shout-out, and I'll be more than happy to work with you on that.
All right. Another question we have here, how do we document all of the good suggestions that you recommend in an electronic medical record system that has limited space to type?
So I get that question a lot. How do we document in an electronic medical record that has limited space to cite? I would say either A, reach out to your EHR and ask them to build a form for you that's just a blank note form. I prefer documentation in the narrative method rather than in DAP or SOAP. I think the narrative will hit all of the points that matter. I think that, also, if you can document, and if you can't get your EHR to play ball with you, writing a clear, legible paper note and uploading it into the charts, attaching it to the documentation that is provided by the payer, that always helps, but you really just have to make sure that you're getting everything in there. You know what I mean? So those are my two suggestions. Either have them adjust the EHR for you. A good EHR vendor will be happy to either create or work with their forms to open up fields, or write it and get it uploaded and attach it.
All right. Can you provide an example of documenting the need for a patient to continue a stay in detox, something other than saying that the patient is still symptomatic? What do you do there?
Okay, so detox is driven entirely by medical necessity, right? So take all your feelings out of it. So if this guy comes in and they're all hopped up on church juice or whatever, as their symptoms start to titrate down, you're going to have to start to look to move them out. But documenting their physical symptomology, their necessity for 24-hour-a-day medical care, there's the key, right? They must have to see somebody every day, all day long, in order to stay in the detox level of care. So documenting, vitals, any changes to vitals, any fall, anything medical will latch onto that. And if those medical symptoms abate, you must titrate them down. It's that simple. You can't hold them in a level of care not appropriate, especially the detox level of care. Now, if they're still on medication, documenting the necessity for that medication and the symptomology that medication is treating is very important, especially if it's detox medication. But it's also, can those be managed on an outpatient level of care? If that's so, they're going to look to titrate them down fairly quickly. So again, it's really driven by that medical need for 24-hour care, not any other reason. Like if they just are not comfortable stepping down or whatever, or you guys have this fixed level of care for detox, you guys are just going to have to get over it and, move them down a level of care, because if you treat them at a detox level of care and send in the chart, and the chart does not support, they will deny the entire detox stay. They will just say, chancleta bicicleta, and it's gone.
All right. Question from a member of our audience. If we have a group of 10 individuals, is it all right for the intervention to be the same for each client? Or do your documentation, intervention, progress, service recommendation plan, and next steps, so those have to be specific to each client?
Yes. I mean, there's no other way around it. They have to be specific to each client. No one client is going to have the same experience as another in the group. It may seem that way, but you must chart what impact that group has specifically on that client. Now, if all of the clients have the same problem, right? Like if there's three of us, if John, Miranda, and Jamie all get kicked out of group for misbehaving or drinking a bunch of culottes and going all hyper running around the group, and they all get kicked out and they all get referred to their primary therapist and they all get put on behavioral contract. If it just so happens to be that all those interventions are the same, document them the same, but you still need to document individually what the experience was for the patient.
All right. Everything you're talking about with documentation and whatnot today, does this apply, or how does it apply for a provider who doesn't work with insurance plans but will give a receipt for reimbursement to the client? Does it change the workflow for those providers?
All right, so whoever asked that question is super smart. Somebody give them a happy Halloween present, because that's a great question. I get this question at least once every couple of weeks. If you don't accept insurance but you work on a courtesy bill basis or you provide an invoice, the first thing that that the families are going to require, or that the payers are going to require that the families include with submission of the bill, is the chart. And if the chart doesn't meet the payer standards, the family will not get reimbursed. So the same documentation rules apply if the expectation is to pass them along to a family to get reimbursed.
All right. Well, I think that is going to be all the time that we have for questions for today. Thanks, John. It was good stuff there, and I think that was a good note to end on. So as we wrap up here, we do have some final instructions regarding CE credit. Please do not leave this page. Continue to stay on the platform, and the site will automatically redirect you to a survey. And this survey must be completed in order to generate your CE certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab to the right of the slides and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event here today on October 31st, 2017. If you enjoyed today's program, please consider joining us on November 14th for Complying with the New Joint Commission Outcome Measurement Requirement, presented by Joanna Conti, CEO of Vista Research Group. The link to register is located in the Resources tab to the right of the presentation window. I want to thank John Raymond once again for an excellent presentation. I'd also like to thank our co-sponsors, Foundations Recovery Network and Panacea, for making today's program possible. And finally, thank you to those of you in our audience for participating today. We hope you'll join us in the future for another Addiction Professional webinar. This concludes today's presentation. Have a great day.